Hello, and thank you to everyone for joining me today for another Leadership Rounds discussion. I'm Rod Hochman, the President and CEO of Providence, and the board chair this year of the American Hospital Association. This month, we're going to talk about a really important topic, rural healthcare. We've seen that our rural hospitals play a crucial role in caring for communities during this pandemic. But we know they're facing some of the most significant challenges. More than 130 rural hospitals have closed in the last 10 years. Another 453 rural hospitals across the nation have indicated that they are vulnerable to closure, which would reduce access to healthcare for many Americans across this whole country. 48% of rural hospitals report that they had negative operating margins. These data points are just a snapshot of the reality of rural healthcare. With the pandemic piling onto the struggles for our rural hospitals, it's vital that we figure this out, how to strengthen and sustain this vital sector of our hospital network. And that is why I'm so pleased to have a hospital leader with me today to talk about the reality of delivering healthcare in rural America. Alvin Hoover is the CEO of the King's Daughter Medical Center located in Brookhaven, Mississippi, a town of 12,000. And just to give you a perspective, I'm in Orange County today in a county of 3 million. So that tells you about how diverse this country is. I'm interested today really in kind of learning how King's Daughter is handling the pressures related to COVID. And hopefully as we talk, we might also tease out some strategies that will accelerate this shift to a more integrated and sustainable rural health system. And as you all know, rural healthcare is one of the major objectives that we have in our strategic plan at AHA. King's Daughter is the medical center, a 79-bed sole community hospital, serving a disproportionate share of Medicare and Medicaid patients. They provide a full scope of inpatient, acute, and emergency services, and they operate 5 health clinics offering primary and specialty services to almost 100,000 people in the surrounding service area. Alvin has been CEO since 2007, and under his leadership, the medical center focuses on, quote, I'm going to quote you, getting it right every time, end quote, to provide safe, effective, high-quality healthcare and wellness services. Prior to joining KDMC, Alvin was the CEO of the Abbeville Area Medical Center, another rural healthcare facility in South Carolina. 20 years of distinguished service in hospital administration. He has a special interest in rural health policy development, advocacy, and mentoring young healthcare executives. He has served as the chairman of the Mississippi Hospital Association Board of Governors and is the past chairman of the American Hospital Association's Rural Health Services Committee. Alvin is also involved in serving the Brookhaven, Lincoln County community, holding leadership positions with the Chamber of Commerce, Industrial Development Foundation, and the Economic Development Alliance. I'm looking forward to hearing Alvin's insights on how King's Daughter has served its community and weathered the pandemic. So, Alvin, a very warm AHA welcome, and thanks for joining us today for the Leadership Rounds discussion.
Thank you, Rod. I'm glad to be here. It's an honor to be able to speak on behalf of rural hospitals and particularly for King's Daughter Medical Center.
Great. Well, I'm going to jump right in and ask you some questions so that we can hear it really from the front lines. And you know, what we understand that King's Daughter's Medical Center has implemented a variety of different strategies and operational shifts with the surge in COVID patients this last year. Tell me a little bit about what strategies you found were helpful and successful. It'd be great to hear that from you.
Sure. The first thing we did, Rod, when the news started coming out globally, there's a new disease out there. It's giving problems and looked like there was going to be a pandemic and maybe it's coming to the United States. We just assigned one of our senior leaders to follow COVID and keep up with it and let us know if it was going to be a problem for us. So the end of December, one of my leaders was just on it. And she would bring our report every week into our operations meeting and keep us abreast of what was happening worldwide. So as it began to hit in the United States, we ramped up our efforts a little bit, just learning about COVID and being aware of it. And it wasn't long before we had our first case, first part of March. We had our first case here in Brookhaven, and then by mid-March, the state had declared a state of emergency for the pandemic, and we went full bore into it with we set up a COVID team. We'd already identified the members of it. We set up regular meetings to have with that. As we progressed into it pretty quickly, we had to close down our surgeries and our physician clinics. So, we watched those revenues just kind of poof. And as much as we tried to be prepared for that, it's just hard to prepare for when there's no money coming in the door, at least no new revenues coming in. We were careful to make sure that we were collecting the money that was in the process. And we actually saw our days cash increase over that first month when we cut our services back. But it was just a matter of being adaptable, right?
Yeah. Well, how did you do? The thing I just, I can relate so much. I'm in a really large system on the other end of the spectrum. And how panicky we were about finding the right supplies, finding out where you got them. Maybe a little bit of your commentary on how did you scramble to get all that done? I found it overwhelming, but we got a lot of resources, and there's always someone to call. And I know when you're in a place like you are, where you are, it's all on your shoulders to get that done.
We're a private, not-for-profit hospital. We're independent. We have a management contract in place with Quorum Health Resources, so we have a little bit of help for some things there. But, for the most part, I think most hospitals found themselves in a world of hurt when we saw the first surge hit, right? At the end of March, our normal volume is about 28, 29 heads in beds in the hospital, so inpatient observations. We saw that number jump up to about 35 or 40. And then all of a sudden, we had 12 or 14 COVID patients in the hospital. That was a lot for us. And, it increased our volume by about 50%. And then the other volume started dropping off, and it became more COVID. We had 23, 24 inpatient COVID. And we were gowning up for everything. The first little bit, we couldn't separate folks in the hospital because we're just not that large. And we saw our PPE go from 45 days down to about 2 weeks. And N95 masks, if we'd used them every day, we were out. And so we went into that routine where we cleaned them. We issued one for 5 days, and then we cut it back to 3 days to kind of follow the CDC guidelines. Gowns were getting scarce in a hurry, and so we had to figure out how we could not throw them away but keep them clean and safe. And eventually we were running out of gowns, and we found a local company that makes garbage bags, plastic garbage bags, and we called them and said, we heard about a hospital that was just cutting a hole in them and putting them on, and we said, can you make us a gown out of that? And they said, we think we can. And so they put arms on plastic garbage bags. They cut a hole, so you just pull it over your head, a little perforation down the back so you could just rip it off. Pretty amazing turn of events. And we were able to pick those up at a fraction of the cost of gowns on the, gray market, almost black market type purchases that were having to be made. And so we were able to get 2,000 gowns in a week, and that would keep us in good shape from a PPE perspective on gowning and mask. And it was frightening for our employees, right? I'm sure it was in the large hospitals. You've got COVID, you don't know how it's really transmitted, it's pretty contagious, and the level of anxiety rose pretty quickly among those staff. And we could spend all day talking about the stories of staff. And
yeah, just maybe a quick note on that as we get to the larger issues of rural healthcare. I think the one thing we've all been worried about is how is our staff going to do? They've kind of weathered 2020, but I think a lot of us are just worried about what's the long-term consequences of going through this whole crisis. What's the picture look like for you, for the staff?
Our staff is pretty resilient. We've had a great culture here. We've been a modern healthcare best places to work 8 out of the last 9 years. And so we have a culture where we take care of each other and we care. And it's gotten us through, this spring, as we've seen COVID decline a little bit. We hope we're kind of through with it for now. I'm afraid there's a 4th surge coming for us in Mississippi, but our staff help take care of each other. We've added some chaplaincy. We've made sure that our employee assistance programs are in place, and that our folks are aware of them. But you can see, as we've been in it for a year, that there are just some folks that are tired and worn out, and their anxiety levels are up. Some folks are a little depressed. I don't really know how we're going to handle it, other than we're going to continue to love them. We're going to continue to make resources available, and we're going to continue to tell them how much we appreciate what they've done and what a great job they've done for us. I mean, it's just phenomenal when you look back on the workforce. I know in large cities, you saw a lot of turnover in the hospitals, and even some of my colleagues in the small rural hospitals saw a lot of people turnover. They'd come in and say, "I can't take it anymore. I'm just going to quit." We didn't see much of that. We saw a lot of teamwork. One of our nurses said, I interviewed them for a little story we did at the hospital, and she said, I've been here for about 3 years. She's been in administration and supervision at other hospitals. She's just an ICU nurse right now. She said, our team comes and asks what they can do for you before you get ready to say, I need help. So we've had tremendous recovery, and I think that that's the case in a lot of rural hospitals. I hear that story from a lot of my colleagues, and we weren't brutalized by the travel companies that came in and ripped your nurses out from under you. We had a few nurses leave, but for the most part, they hung in there with us and stayed and worked hard. Not just nurses, but the whole staff. Respiratory therapists, you can't say enough about those guys and the work that they've done.
So Alvin, let's pivot here. Let me ask you, as someone who's kind of lived your whole career in this setting and has been a real spokesman, let me ask you, what do you think the future is for rural healthcare? And I think the whole audience would love to hear some of your ideas. And what do you think we need to do this year and beyond to preserve rural healthcare?
Well, we've got to make sure that we can get reimbursed for the work that we do. In rural communities, we see a lot of Medicare, Medicaid. 75% of our business is typically those payers that you're lucky to get paid cost out of. If you're a critical access hospital, you can maybe make 1% on the end of your Medicare business, but it's tough in rural hospitals to find the services that you're going to use and to keep folks coming into your hospitals. In our case, we're a sole community hospital. We qualify for 340B, and I'm really concerned throughout the pandemic that a lot of smaller hospitals rural hospitals have seen their volumes decline, and that may impact their ability to be a 340B or to remain a dish hospital. And it's important that we maintain those programs for rural hospitals, for sure.
Right. So those are some of the majors that we need to make sure that they get supported, and we make sure that those are there. What about the structure of rural healthcare, or how it's organized, the networks? Any other thoughts for the audience on that?
Well, we've seen rural hospitals reach out to larger partners to say, how do you help us? Because we can be a referral center for larger organizations in urban areas. Again, it comes back to how savvy you can be in your community to provide the services that they need. In our case, we've added wound care, we've added a pain clinic, we've added varicose vein. We've looked for niche services that people need that they can stay local and get that work done and think of us first. We want to make sure that rural hospitals can provide primary care and emergency care. And it may be that there's not enough inpatient business to keep them there. And so we may need to look at how rural hospitals are structured, how Medicare or CMS defines a hospital so that you don't have to do inpatient care to continue to be a hospital and serve your community. Hospitals close in small communities. You see a lot of them dry up and really not have the services that they need. Our hospital is the largest employer in the county, the second largest employer in the county. We've got a Walmart distribution center that employs about 1,000 people. We employ about 650 and have another, close to 1,000 people either contracted or in service with the hospital. So small hospitals, even in smaller communities than we are, certainly the largest employer in their community. And when you see that go away, not only healthcare services, but the economy of that community dries up. So
because what I think we've seen is that what we thought we had as a public health system, we really don't have. And I think one of the issues that's going to be discussed is what do we do about that? And I, personally see that, the rural safety net that we have out there is really, it is you are the public health provider in your county and where you are. And the question is, how does that get supported? And, with your clinics, more just beyond the walls of the hospital, but what else you're doing in the community. And I think that's an area that I think you've done at King's Daughters, you've already kind of moved into, but more to come, I think, in that whole area.
Yeah, again, you can come back and say, how do you get reimbursed for doing those things that you're doing in the community? And having physician clinics, I haven't figured out how to make physician clinics make money. From the hospital side, they send business and I make money, and then it kind of balances out that, I can at least afford to make that service available because I'm making enough over here to pay for what I'm losing over there. One thing that help us in Mississippi and there's, I think 12 or 13 states now that haven't expanded Medicaid. We need to expand Medicaid. It needs to be a focus. And, in our state, we're Republican state for the most part. They talk about expansion as Obamacare, and what it is expansion is taking care of your communities. Expansion is giving your community, your state, an economic boost. And especially as we come out of the COVID pandemic, what we've seen over the last year, our state and our healthcare system need that boost of a Medicaid expansion. And I'll just briefly tell you, in Mississippi, we've got a proposal out from the Hospital Association that says we call it Mississippi Cares, and we're willing to front the money for it, so the state won't have to pay it. There'll be a provider tax and some member premiums that pay for it. It draws it down. It really is sort of a Medicaid reform because it's different than just pure Medicaid. And we're excited about it, but we're having a hard time getting traction with it here. And I know other states have faced those same problems, even though we've seen 2 or 3 added in the last year or so. But it's an uphill battle. And that, if we can pay for the services that we do, we'll do them.
Right.
We can go from here into dealing with health inequities and disparities. And, I don't want to have any disparity in my hospital, but I don't have good data to show that I don't. How do I do that? And, the one example I can give you is just the vaccines. I know that's something we're probably going to talk about.
That was the next one on my list. And we'd be remiss if we didn't, we can't have a conversation in healthcare without talking about vaccines. So, I think everyone's interested in how are you doing? And
the state health department is coordinating vaccines across the state, and they're doing regionally setting those up, and I forget how many a day they're doing, but we're getting shots in arms across the state. But locally, it's hard for everybody to get out there, especially that 75 plus, 65 plus sometimes don't have access to transportation. And so we got the state, they send us somewhere between 200 and 500 vaccines a week that we give. As we gave the first couple of weeks out, we advertised on our website, our Facebook, our Instagram, we put it in the newspaper. But our community, our county is about 70% white, 30% black. And we just saw white people coming to get the vaccine. And by the second week, we said, time out. What can we do to make sure that we're getting this available to everybody, in particular our black community that hadn't shown up yet? So we contacted black pastors, black churches, and civic clubs, people that were influential in town, and said, how can we make sure that transportation is not a problem and that people aren't afraid to get the vaccine? And so we put that out, and over the next 2 weeks, we saw those numbers even out, really even a couple of weeks, a little bit higher on the black side than the white side, and then even out over time to meet pretty much what our demographic is. So I feel good that we're able to do that. But you go back again to the disparities, identifying healthcare disparities, poor and black, they're there. I know they are, and I need some help identifying that. And I saw the AHA has an initiative coming out to address that, and I'm looking forward to maybe being.
Because I think, Alvin, you and I have been in healthcare a long time. We've been staring at this problem, observing it, and it kind of reminds me of the whole safety quality thing a while ago. Crossing the chasm. We kind of knew it was there, but it took some momentum to get things done. And maybe this is one of the good things coming out of the COVID, is that we're going to finally address it and put in action and be able to do it. And I think the AHA and all the hospitals really want to take that one on. And I think that's one that I think we feel is important, but it's important to get it in the rural settings as well as in cities and elsewhere, and doing all of that. So I don't know this is a great conversation. We could go on, but I know that speaking on behalf of the AHA, we want to enlist the advice, support of our rural hospital brothers and sisters out there to figure out how we really take this on. And Rick and the staff at AHA has done a lot to try to make sure we get the funding for rural hospitals, get some of those things done. But then I think we need to come up with a comprehensive plan that protects this way of care in the country. And I think this is one of those exciting things that we actually have a crack at getting done, which is something out there. And I think we got to seize the moment. This is the one time that people actually like their doctors, nurses, and hospitals. And we should go with it. So it's great having you with us today, and more to come. And I know you and I will probably have some more conversations as this year goes on. So thank you so much for being with us.
You're welcome, Rod. I enjoyed it.
Great. Same here.